Hi everyone, and welcome to our webinar today on central post-stroke pain. My name is Jillian Tallman and I'm a communications officer here at McMaster. Today's webinar is part of the Pain HQ project. It's a web resource dedicated to neuropathic pain, and we have with us today Dr. Jason Busse from McMaster. He's one of our pain experts who has contributed to the site. His clinical interests include insurance medicine, orthopedic trauma, chronic pain, and other medically unexplained syndromes, and the management of complex disability. He is the co-principal investigator of the TRUST trial, which looks at pulsed ultrasound bone stimulation in patients undergoing intramedullary nailing for tibial fracture. Dr. Busse is also interested in methodological research, including expertise-based randomization and the use of composite endpoints in clinical trials. And I know that his research interests will certainly play a role in our discussion today. So with that, I will turn it over to Jason.
Well, thank you very much, Jillian. So thank you for joining the webinar. We're going to be talking today about management of central post-stroke pain, and in particular, discussing the results of a recent study that we've just had accepted for publication. Next slide, please. Central post-stroke pain, often short-formed as CPSP, is a chronic neuropathic disorder that can occur after an injury or disease that affects the central nervous system. The central nervous system being the brain or the spinal cord. And as per the name, the insult is often, you see the insult in the form of a stroke, and the pain complaint then develops after the stroke. Next. And so how common is central post-stroke pain? The prevalence can be difficult to determine because after an individual experiences a stroke, there can be a number of painful complaints that arise. Persistent headache, shoulder pain, painful spasms are all part of common experiences after a stroke, but central post-stroke pain is a distinct type of pain. There has been a very large study that was published recently where they followed close to 16,000 stroke patients from 35 different countries, and by using very strict criteria, they estimated that about 3% of patients had developed central post-stroke pain that was persisting 1 year after the initial stroke had happened. And the prevalence is variable within this population, however, and it also depends on which part of the central nervous system is affected by the stroke that you've had. To give an example, one study that looked at patients that had a brainstem injury found that 25% had presented with central post-stroke pain at 6 months of the stroke. So the prevalence can be quite variable, but we're looking at an overall prevalence of about 3% of all patients that experience a stroke. Now, how do patients experience this type of lesion, this type of syndrome? Very commonly, the parts of the brain that are affected by the stroke will be the ones that are affected in central post-stroke pain. And so you'll see pain and sensory differences result where the brain or the spine has been injured by the stroke itself. And you'll see this manifested in often two very distinct ways. One is sensory loss. So certain parts of the body that are supplied by the brain that's been injured will no longer feel normal sensations. Touch and pressure, for example, will be absent. And you'll then also develop this sort of central sensitization, what they call neuronal hyperexcitability. And when the brain is not interpreting normal sensory sensations from an area, it can begin to recode senses coming in as painful. And this is a result of the damaging of the sensory pathways, and then the brain is attempting to correct this absence of sensation, and so it begins to interpret senses that come to that area, or touch or pressure, as very, very painful. And so this is sort of the dual presentation you see, and there's a graphic representation, if you just click one more time, which shows this idea about the sensory nerves being interrupted, and then you get the abnormal sensory processing, which can be misinterpreted as very painful sensation. Next. This is not unique to central post-stroke pain, but whenever an individual experiences chronic pain, and by chronic pain we usually mean pain that has persisted for at least 3 months, there are a number of consequences to that. From a physical perspective, being in pain will often result in individuals avoiding activity, avoiding physical activity. This then results in weakening of the muscles and progressive deconditioning. And as they become less and less tolerant to activity, they're able to do less and less, and it becomes what they refer to here as a physical vicious circle. There's also a vicious psychological circle. If you are in pain all the time, it is a natural reaction to become frustrated, to be in distress, even to be fairly angry about this persistent state. This then, of course, will lead to reductions in your mood, which can result in depression. And we know from a number of studies that when we are feeling depressed, when we are feeling anxious, it actually accentuates the severity of pain that we're feeling. And so you have these two vicious circles that are initiated and persist with chronic pain, but it also provides us with potential targets. If there's a way for us to reverse either the physical circle or the psychological circle, even though that doesn't treat directly the underlying cause of pain, we can often see improvements, which is why even if there's pain due to a number of different causes, the clinical approach will often be to try to encourage increased physical activity and treating any comorbid mood disorders that might have resulted. Again, these things will not cure the underlying cause of chronic pain, but they can improve symptoms and they can improve functional capacity. Next. Now, when clinicians and patients are trying to decide what type of therapy should I pursue for my central post-stroke pain, there's a lot of different types of research that they can look to. And what I've put on this slide here is what's called an evidence hierarchy. It's a pyramid, and the types of study designs that are more towards the top of the pyramid are those designs that are less vulnerable to bias, which means that we are more likely to be able to be confident in the results from the higher study designs than we are in the lower. So you'll see that down near the bottom we have opinion, we have case series, so perhaps a clinician will have found a couple of cases of patients with central post-stroke pain, and he believes they've had a favorable response to treatment, and he's written that up. As we go higher at the top, we see the randomized trials. These, if done well, are at much lower risk of potential bias because we're not selecting cases that we like or ones that we may have come across in our personal experience, but we're taking ideally a group of fairly similar patients, and we are randomizing them to either receive a treatment or to not receive a treatment. And if we have successfully randomized them, then patients in both groups, whether they're receiving the treatment or the control, should be at the same prognostic point. So if you followed them forward, they would each have the same outcomes. So if you see a difference in the outcomes between your treated and your control group, you can be much more confident that that difference is due to the treatment that you are testing. Now, if we have a number of randomized trials available, we can do what's called a systematic review of these randomized controlled trials, or RCTs. And a systematic review simply means that we are taking a very systematic approach to acquiring all of the relevant trials to inform a given treatment for a given condition, and we are synthesizing them or summarizing the overall effects. And this is the most rigorous way to appraise existing knowledge for different therapeutic options. And what I'm going to be talking about as we proceed in this presentation is our recent systematic review looking at all treatments for central post-stroke pain that have been explored in the context of a randomized trial. That's not to say that other therapies may not be effective as well. There may be therapies that have been explored in other types of studies, observational studies or case series, that may indeed be very promising. But those studies are going to be at a higher risk of potential bias, and it is more difficult to really know what the true treatment effect is, which is why we've restricted our review only to randomized controlled trials. Next. So the core concept of a systematic review is that you are able to locate all of the relevant literature to inform a given clinical question. And so what we did is we worked with an experienced medical librarian who developed detailed search strategies for all relevant literature, and then we searched 8 major electronic literature databases. So we felt we made a very comprehensive effort to find any existing trials that could help us answer our question, which is what treatments have been tested to improve symptoms associated with central post-stroke pain. And what kind of studies were we interested in? Well, we were interested in randomized controlled trials, or RCTs, of any therapy, as long as they enrolled more than at least 10 patients or more. And we did that on the basis that very, very small trials are unlikely to provide a lot of information. And we also wanted them to report outcomes, patient outcomes. By that I mean pain relief or improvement in functioning at least 2 weeks or more after the treatment. And we did this because there are studies that will only test the effect of a therapy a few minutes or a few hours after treatment. They're not really meant to inform clinical decision-making. They're more studies looking at how people process pain or how people's systems might react very quickly to something. But patients are much more interested in how a given therapy will affect their pain and their ability to function at longer time periods. And the other hallmark feature of a systematic review, so one is to find all of the available information, not just the information that you might be aware of, and the other hallmark is to perform any subjective step independently and in duplicate. And this gives us a much higher level of confidence that if another group of researchers undertook the same systematic review that we did, that they would also find the same results. And that's called reliability. And that's, again, a critical feature of a systematic review. And one of the real advantages of a systematic review is that ideally, if you find a number of trials that have looked at a similar therapy on a similar outcome, you can actually combine all of those trials to create a very, very large trial. And the advantage of this is that any time you administer a treatment to a patient population, so in this case, patients with central post-stroke pain, some patients will respond better than others. And you have variability in response to any treatment. And it's difficult then to know what the average treatment that a patient can expect is. If we only have a trial of, say, 10 patients, we might see a lot of variability in treatment response. And we call that imprecision. And so we can tell patients, well, the average effect might be a 10% reduction in your pain, but because it was based on a very small trial where some patients, of course, are going to do better than others, you might see as much as a 20% reduction in pain, or maybe as low as a 5% reduction. And as we add more and more patients and more observations, we reduce the imprecision, and we're able to give people a better and better idea about what type of treatment effect they can expect. So again, by pooling a number of smaller trials together, we reduce the uncertainty around the average treatment effect, and we can be more confident in communicating to patients what type of response they're likely to see. Next. I mentioned before when we were looking at the evidence hierarchy that typically randomized controlled trials are at the top of the pyramid. They are the studies that are at risk, the lowest risk of bias, and we can generally be very confident in the results they provide. However, not all trials are done well. Some are done better than others. And we want to be able to understand, is the evidence that we have coming from very high quality trials, or are there some concerns with the studies, and we maybe should be more cautious in terms of interpreting the results. And a strategy that has now been adopted by many organizations, including the American Medical Association and the World Health Organization, and a number of very influential organizations, is called the GRADE approach. And the GRADE approach allows us to categorize the quality of evidence that we derive from a systematic review as either high, moderate, low, or very low. High quality evidence means that we are very confident in terms of the data, very confident in terms of using the information to drive clinical decision making. And as we go from moderate to low or very low, we have decreasing confidence. And evidence that is low or very low in quality is very likely to be affected by new research that comes out. So how does a study go from high to moderate, low, or very low? Well, randomized controlled trials begin as high quality, but they can be rated down due to one of 5 reasons. The first reason you see here is risk of bias. So for example, if a study enrolled 100 patients, but for whatever reason they lost track of 50 of them before they could measure the outcome, that would be an issue that would present a risk of bias. If they lost a lot of patients due to follow-up, we don't know if the patients that they lost are the same as the patients that stayed in the trial. They're probably very different, and so it decreases our confidence in their findings. The next category you see there is something called inconsistency. If we have one trial that says the treatment is very effective, another trial that says the treatment is very ineffective, then we have reason to question our confidence in the overall result. We also have, as a third category, indirectness. For example, if we find that the existing trials have only enrolled very young patients that are otherwise very healthy and they had very, very mild strokes, we would have less confidence in applying those findings to patients that were older or that had more severe strokes, for example, or had a number of other conditions they were struggling with. So that's what we mean by indirectness. The next category is imprecision. And as I mentioned, with a systematic review, we can statistically combine a number of trials to create one very large trial or a larger trial, and that's going to tell us an average estimate of the treatment effect, but it's also going to give us the precision around that estimate. Now, I'm going to give some more details about that, but if our associated precision, so the sort of range over which the true treatment effect might lie, if it includes both a significant effect and evidence of no effect, that gets us to imprecision. And the final category is publication bias. If we see evidence that there have only been positive trials published, so trials that are only showing a significant effect of a given therapy, then that is also going to decrease our confidence because it means that perhaps negative trials have not been published, and we're going to be misled. We're going to be misled if we only believe the evidence that's been published. Next. As I mentioned, we searched 8 large electronic databases, and this is what we call a flow diagram of study selection. This gives you an idea of how much literature we found and how much was eligible for our review. So we began with 8,400 studies that we found. We ended up looking at 324 of these in full text in order to really see which of these was eligible for our review. And there were a number that were not eligible. You can see the reasons in the box to the right of that 324. And in particular, I want to highlight that we had 9 studies that were randomized controlled trials that enrolled patients with central post-stroke pain, and they tested an intervention, but they did not follow their participants for at least 2 weeks. So they only collected the outcomes very, very quickly after the intervention. They were excluded on that basis. When we went through this process, we had 8 randomized controlled trials that were eligible for our review. Next. Now, I mentioned before that one of the important steps of a systematic review is to look to see if we are doing our subjective steps in a consistent and reliable manner. And so we did have 2 independent reviewers going through the article selection process, and they showed essentially perfect agreement. So they both agreed on the 8 studies that were eligible. Next point. Now, what we found, which was quite interesting to us, is that all 8 trials evaluated treatment effects on pain, but none of them reported the effects on physical functioning, what we call role functioning, which might be the ability to work, or interpersonal functioning, how individuals' relationships, how their sort of social relationships are either improving or not with the intervention. These are all outcomes that patients dealing with chronic pain have indicated are very important to them. And so we were surprised that so few trials had looked at these outcomes. We also looked at how long they followed patients. Again, these are all individuals with central post-stroke pain. They're dealing with chronic pain complaints. They're, of course, going to be very interested in not only is a treatment effective, but how long do the effects last? And we found that the longest follow-up amongst our 8 eligible studies ranged from as short as 2 weeks to no more than 12 weeks. So we are dealing with a body of literature that really is only telling us about the clinical outcomes for fairly short time periods. Next. This is a little bit of a busy graph, but I'm going to break it down. All you really need to focus on is the proportion of green circles and the proportion of red circles. At the top, you see the author and the year of publication for the 8 trials that were eligible for our study. And down the side, you see 9 outcome domains that patients with chronic pain have indicated that they want to see information on when making a decision about whether to pursue a given therapy. So as you can see, for the first row, you see a solid line of green circles. Every one of the 8 trials reported the effect of the intervention they tested on pain relief. Next down, you see physical functioning. None of the 8 trials reported the effect of the intervention they tested on the ability to improve patients' physical functioning. And as you go down, you see a real mixture, but there is a lot of red circles, meaning that many of these studies are not reporting the effects of therapy on outcomes that patients want to know about. So again, it's another limitation of the existing literature in this area. Next. This is what we call a forest plot. And as I mentioned to you before, one of the real advantages of a systematic review is that we can sometimes pool a number of small trials together to get the overall estimate of effect. And that's what we've done here. You see that under the heading study or subgroup, we have 4 trials listed. Each of these trials tested the effect of an anticonvulsant versus placebo on pain associated with central post-stroke pain. And you can see at the forest plot itself, under the heading mean difference, each one of the 4 studies is represented by a gray square and a line through that square. The gray square is the average effect that patients reported on their pain when they were, for those patients using an anticonvulsant versus those patients using placebo. So if we go up to the very first study, we can see that the average effect, the average reduction in pain on a 10 centimeter pain scale was 0. So there was no difference between patients that used an anticonvulsant versus those patients that used a placebo. But there was some associated imprecision. So you see the line going through that square, which is at the 0 line, or the line of no effect, suggests that patients may achieve as much as a 1.26 centimeter reduction in their pain. And again, this is on a 10 centimeter scale, or they may actually experience an increase of pain of the same proportion, 1.26 centimeters. And as you see the other studies, as you go down, the next study shows a fairly similar result, but with a much more precision. So they have a much smaller line that goes through the gray square. The third study down, you can see that the gray square is to the left of the zero line, which means it is favoring the anticonvulsant, but the line is quite wide and actually crosses the line of no treatment effect. So here we're dealing with imprecision. We see that the average effect suggests some benefit, but because of the variability in response, we don't know if the average patient is likely to experience more benefit than that or actually no benefit at all. And the final or fourth study that we had is more clear. This one suggests an average reduction in pain of 2 centimeters on a 10 centimeter scale, and the estimate of precision is all to the left of the line of no effect, suggesting that all of the patients experienced some benefit, some less and some more. And what you see in the black diamond below is the result when we pool all of the data from these studies together. So when we do that, you see that the average treatment effect suggests a benefit of a reduction of pain of 0.75 centimeters on a 10 centimeter scale, but there's imprecision. You may experience a benefit as great as 1.71 centimeter reduction in pain, or you may experience a slight increase in your pain. And again, by doing a systematic review, we're unable to choose a study that gives us one result. We pool all of them together, and this is the overall result that we get. Now, an anticonvulsant is a type of drug, and down below you see the sort of 5 most common anticonvulsants that are prescribed for central post-stroke pain, and certainly names such as Neurontin or Lyrica or Topamax may be more familiar. And if you've understood the forest plot, you are now able to interpret the core message of any systematic review. Next. Now, I mentioned that we were going to use the grade approach for estimating the confidence that we have in the evidence to inform effectiveness. So this is a grade table of anticonvulsants versus placebo. And you can see on the first column, we've listed the outcome of interest. We have pain intensity, depressive symptoms, patient-reported global improvement, sleep problems, and any side effect that was reported. We've listed the number of trials that were able to give us information, and also the number of patients. And what you'll see is we have fairly small numbers of trials and fairly small numbers of patients. When you look at the next column over, this is the actual effect. And the first one corresponds to the forest plot that we looked at on the previous slide. And the overall estimate of effect is 0.75 centimeter pain reduction on a 10 centimeter scale. But again, it's imprecise. And if you go over to how we rate the quality of that estimate, we've put it in a very low category in terms of its grade score. We're dealing with imprecision. There were issues about risk of bias that affected the trial. So we're not very confident in that result. And if you go down the effect estimates for the other outcomes of interest to patients, we really don't see much evidence for benefit, whether we look at depressive symptoms, global improvement, no real difference in adverse events. There's the potential for some improvement in self-reported sleep problems, only based on a single trial of 129 patients, and on a a 0 to 100 scale, patients that received an anticonvulsant, on average, reported a 4.2 out of 100 reduction in sleep problems. So again, this is a very, very small effect. Patients typically need to see a difference of at least 10 points on a 0 to 100 scale before they notice the effect. And if you look at quality, you can see that unfortunately we're dealing with really only very low and low quality evidence. So overall, if we're looking at anticonvulsants versus a placebo for treating central post-stroke pain, we really have no compelling evidence of a treatment effect. But at the same time, the evidence available to inform that is of very low or low quality. Next. This is a grade table looking at antidepressants for the treatment of central post-stroke syndrome. And what we can see here is that there was only a single randomized control trial of 15 patients that was available to inform this area. And when they looked at pain, when they looked at depressive symptoms, there was no difference whether patients used an antidepressant or whether they used a placebo. When you look at adverse events, there was a significant difference. Patients who used an antidepressant were much more likely to report an adverse event than if they used placebo. But again, when we look at the overall quality of this evidence, it is very low. So we do not have a lot of evidence to demonstrate whether antidepressants are effective or not. And the very small amount of evidence that we have is of very low quality and does not suggest that there is a benefit. And you can see just above what's appeared is the actual antidepressant that was tested, which in this case was amitriptyline. Next. We also found one trial of only 20 patients that looked at what's called an opioid antagonist. And if you click to the next graphic, you'll see that the specific one that was tested was naloxone. And they only reported the effect on pain intensity, and they simply reported there was no significant benefit. Again, we're looking at one very small trial. Overall quality of the evidence was low. Next. There is a newer therapy that is being promoted to manage symptoms associated with central post-stroke pain, and it's called repetitive transcranial magnetic stimulation. And really what you do if you're a patient with a chronic pain condition such as central post-stroke pain, they want to hold your head very still while they apply a magnetic field to the top of the head. And the magnetic field, they believe, is supposed to help improve the way the brain is processing these sensory signals, which unfortunately, when it becomes dysfunctional, it interprets as pain. Next. So here is our grade table looking at this therapy. And we found only a single trial of 52 patients. It looked at 4 different outcomes that patients would be interested in. Pain intensity, depressive symptoms, patient-reported global improvement, and any adverse events. And what we found is no reporting of any significant effect on any of these outcomes. But again, due to issues of risk of bias and other factors, the overall quality of that evidence is unfortunately very low, which again means that new evidence in this area is very likely to change our interpretation of the effectiveness of this therapy. Next. And next slide. This somewhat dramatic photograph depicts a therapy known as acupuncture. And as you can quickly discern from the picture, this is the careful application of bee venom to areas that are affected by central post-stroke pain and other chronic pain conditions as well. There are two ways to do this. One is, as you see in the picture, define the area you want to target and then carefully apply a live bee to sting the area. The other way is to simply have bee venom and coat the ends of surgical needles or acupuncture needles and then apply it without the process of using a live animal. Next slide. We did find one randomized control trial, or RCT, that explored this therapy. So they coated acupuncture needles in bee venom versus simply coating acupuncture needles in saline solution. They only reported on pain intensity, and they reported that there was no difference whether patients with central post-stroke pain received the bee venom-coated needles or the saline-coated needles. Again, as with the other literature on different therapies, you'll see the overall quality is very low. Next. The final trial that we found in our systematic review looked at the use of electroacupuncture, which you see in the picture to the left. An individual has a number of acupuncture needles inserted in the area that has been affected by their central post-stroke pain, and then each one of those needles is connected to an electrode that will provide a small charge that goes through the area. It's not painful. It really feels like sort of a gentle tingling. And this trial compared electroacupuncture versus an anticonvulsant. And as you remember from our first grade table looking at anticonvulsants, there is not good evidence at this point that anticonvulsants are effective in managing symptoms or functional impairments associated with central post-stroke pain. So what did this study tell us about how well electroacupuncture does versus an anticonvulsant? Next slide. Well, this was one trial of 60 patients. They reported a composite measure which included joint pain, dysfunction, and tenderness together, and they found that there was no difference between patients' reported symptom score, whether they used electroacupuncture or whether they used an anticonvulsant. Again, because of imprecision, inability to blind patients or care providers, and a number of issues, the overall quality of this evidence is considered very low. Next. So in summary, we have very little data from randomized controlled trials or studies that are likely to be at the lowest risk of bias to guide treatment decisions for the management of central post-stroke pain. Next point. Of that evidence, which comes from only 8 randomized controlled trials, typically of fairly small numbers of patients, the existing evidence is only low or very low in quality, which means, again, that newer studies or new evidence will be very likely to change our understanding of how effective these therapies might be. But given the evidence that we have, all of the therapies evaluated to date have not shown a significant effect on either reducing pain or improving other patient-important outcomes that were explored. There was a very small signal with I believe the anticonvulsants that very, very marginally improved sleep symptoms, but the effect was so small that it's unlikely that patients would even notice the effect. Next. Now, There are a number of clinical guidelines that provide recommendations for clinicians who are providing care to patients with central post-stroke pain. The International Association for the Study of Pain has put out one, the European Federation of Neurological Societies, and also the Canadian Pain Society. What do these guidelines recommend? Next. All three guidelines recommend antidepressants as first-line therapy. Now, if you remember back to the evidence that we showed you about antidepressants, there's only been one randomized control trial, only on 15 patients, and the effect on pain was non-significant. Two of these guidelines recommend anticonvulsants as first-line therapy. And if you recall back to the forest plot and the grade table that we showed, looking at anticonvulsants, we really found no evidence for effective treatment either. So why is it that clinical guidelines are providing strong recommendations for therapies that have very, very little evidence, and the evidence behind them does not suggest a significant effect? Well, it's because many of the guidelines use a consensus process. They bring together a number of clinical experts, and they come to a consensus on what they believe might be helpful. But because the evidence underlying these recommendations is not supportive, there's good reason to question whether even following the clinical guidelines will result in meaningful improvement. Next. Now, there's very, very little evidence, unfortunately, in the form of randomized controlled trials to inform treatment options for central post-stroke pain. However, there are a number of other neuropathic pain conditions that we do have a lot of evidence for. And it's possible, by looking at how patients with other neuropathic pain conditions respond to different therapies, may give us some ideas about treating patients with central post-stroke pain. So our group here at McMaster has started about six months ago now a very large systematic review looking not for central post-stroke pain, but looking for all treatments that have been tested in randomized controlled trials across all neuropathic pain conditions. We hope to have this completed in the next year or two. It's a very large undertaking, and we're hopeful that we're going to be able to learn about some promising therapies for improving symptoms and functional impairment for patients dealing with central post-stroke pain from all of the other evidence on neuropathic pain conditions. Next. So in conclusion, central post-stroke pain is a debilitating condition, and the available evidence that currently exists from the 8 randomized controlled trials does not support guideline-recommended care or suggest a clear therapeutic option for managing this condition. Further research and innovative treatment approaches are urgently needed to improve care of this very important patient population. Next. You've come to this presentation and been made aware that we have a website called Pain HQ, and this is one of the resources that we are hoping to use to gather information on potentially promising therapies for treating neuropathic pain conditions in general, and in this case, central post-stroke pain in particular. And I would encourage you, if you are dealing with central post-stroke pain, or if you know individuals that are, if you are able to come to Pain HQ, and if you come to the site, you'll see opportunities to provide your experiences with different treatments. If you found something that you believe was helpful, if you found something that has helped you, we would like to know about it. We do look at the website regularly, and we'll use the information that you provide to help guide the research that we're doing here at McMaster. So I encourage you, if you have some experience in this area, or if you know others that have, please let us know, and we would be very happy to receive that information and use that to help better our understanding of how we can help patients dealing with central post-stroke pain. Thank you very much for your time. This concludes the formal presentation, and I'd be happy to entertain any questions that you might have.
Thank you, Jason. If you do have any questions, feel free to enter them into the chat box. It might look a little bit different depending if you're logged on from the web or if you have it on your desktop. So we'll just leave that open for a couple minutes and see if anyone has any questions to send through. I was actually wondering, during your presentation, you had mentioned that pain is measured in centimeters, and I was wondering if you could explain why that is.
Yeah, it's an excellent question. So pain is measured in many, many, many different ways, and in order for us to statistically combine the trial data, we need to convert all of the outcome measures to a common scale. And so some of the studies reported pain on a 10-centimeter scale, where they essentially ask patients to indicate their pain before they start treatment and their pain after they have completed treatment. And we were able to convert all of the studies to that 10-centimeter scale for the purposes of providing a combined estimate of the treatment effect. So not all studies will use this 10-centimeter scale. A number did, I believe, at least 2 out of the 4. And we needed to convert to a common scale so that we could provide that pooled estimate of effect that I demonstrated on the forest plot.
Is it, just out of curiosity, is it at all related to the idea of, rate your pain on a scale of 1 to 10?
Yes, that's exactly what it's based on. The instrument is really meant to provide patients with a way to clearly indicate the level of pain that they're experiencing, and so they'll often provide a simple line, and they'll anchor the line. They'll say, the far left of the line is 0, it means you have no pain. The far right of the line is a complete 10 out of 10, and please indicate where you are on this line. And then they do that before the intervention, they do that after the intervention, and that allows them an idea about how much improvement or lack of improvement the patient has experienced. I'm seeing a question in the chat window which says, if my loved one has central post-stroke pain, should I encourage her to try different treatments or doctors suggest, or just not bother? That's an excellent question, and I do want to convey that even though our results did not identify a clear treatment for central post-stroke pain, the evidence, as I said, was either low or very low in quality, and a lot of that was due to imprecision. Jillian, are you able to go back to the forest plot looking at anticonvulsants, just so I can illustrate that point?
Yep, I'm on my way.
It's a little further back to summarize. We found a lot of imprecision. So if you remember back to the anticonvulsants, just using that as an example, the overall treatment effect suggested that on average patients reported a 0.75 centimeter reduction in pain. Oh, there it is. Or a 0.75 reduction in pain, but some patients experienced as much as a 1.71 reduction in pain. Some patients experienced a very slight increase in pain. You don't know what the true effect is. So it would be quite reasonable for patients to try different therapeutic options, because it may be that they are one of those individuals that's going to experience a larger reduction in pain. They may not experience a reduction in pain, but you don't know till you try. So when you're dealing with low and very low quality evidence, if there's a suggestion that a treatment effect might be there, then I think it's quite reasonable to try a therapy. We simply don't know if it's going to benefit someone, but our estimates suggest that some patients have seen a benefit. Future research is very likely to change recommendations around, for example, use of anticonvulsants, but you don't want to discourage people from trying a therapy simply because the evidence is not well developed. I think it's very reasonable to look at the results from work such as ours to provide some guidance for where there appears to be at least some evidence, and maybe to talk with your provider about what their experience has been with other similar patients, and certainly to try treatment options, simply being aware that it's difficult to say what the actual effect on an individual is going to be with these different treatment options, but certainly worth trying.